everyone. Welcome to the Happy Flosser podcast. My name is Billy Luntz. I am your host, and I'm here to talk to you about all things dental hygiene to support you on your journey through the dental hygiene program. It is really fantastic to be with you today. And today's topic, we are going to talk about radiographic interpretation because I know that many of you struggle with this. And today's topic, we're going to be covering that to help you overcome the issue of what are the steps that I need to be doing with interpreting my radiographs. And honestly, the better you interpret your radiographs, the better you'll be as a clinician at detecting early detection of and helping the dentist diagnose disease. And these radiographic interpretations, I have a step-by-step guide in my new radiographic study notes book that will be coming out later this month. So I'm really excited about it. It's everything radiology, including interpretation, sensor placement for all of your images, and soup to nuts, pretty much everything you need to know for radiology. But today's episode, we are talking about radiographic interpretation. So it is a systematized evaluation of dental images, and every single clinician does it just a little bit different. And really what we're doing when we do it, we are looking for normal anatomy, we're looking for variations, and we're looking for different signs of disease. And this is a skill. You have to flex this muscle of using your eyes, connecting it with your knowledge, and interpreting those radiographs. Because honestly, the radiographs tell us such a vast amount of information about what's going on with your patient. So the first thing you need to do is to come up with a diagnostic set of x-rays, which sounds pretty easy, doesn't it? We all know how complicated radiology images are. No cone cuts, no overlaps, no motion of your patient, correct angulation, proper density and contrast, complete coverage of all the areas of interest, aligning with, all the rules that you had to learn in radiology to get proper imaging in order to get a diagnostic set of quality images. That's really the foundation that starts you off on the right foot to doing proper interpretation of radiographs. The next thing you want to do, now everyone tackles this just a little bit different. And I'll tell you what the textbook tells you. The textbook tells you to start in quadrant 1 and then just scan the whole the whole mouth. It doesn't matter if that's what you do or not. What really matters is that you're checking everything. You're looking at the broad scope. You're looking at all of the major landmarks, all of the structures, right? You're looking at all of the anatomical features, looking at the maxilla, the mandible. You're looking at the trabecular patterns of bone, the alveolar crest height, the periodontal ligament space, the lamina dura, looking to see if everything looks normal there for anatomy. And you're going to you can do however systematized you want to do. I tend to look at all of the crowns of all of the teeth. I evaluate all of the enamel and the dentin and the restorations. And then I go back around and I focus on the pulp and the pulp chambers and make sure everything looks okay there. And then I might examine the roots. I might be looking for variations or dilacerations, or I might be looking for some kind of anatomical features, any anomalies that might be present. And then the periodontal ligament space specifically, I'm looking to make sure there's continuity there. I'm checking the lamina dura, making sure there's nothing that's a standout. Is there any widening of the periodontal ligament space? And then I'm looking at the bone levels around the teeth. What does the crestal bone look like? What does the horizontal bone look like? Are there any vertical defects? I'm looking at the support structures around the teeth. So I tend to look first at kind of the big picture. I look at the TMJ, I look at the mandible, I look at the maxilla, I look at the sinuses, and then I kind of hone in on the teeth themselves, and then I start looking around the teeth. Now, that's completely my strategy. That's how I tackle radiographic interpretation. That does not mean that's how you have to tackle radiographic interpretation. So after I do that, I move on and start looking at existing restorations or the need for restorations. So I'm going to look through the mouth at the amalgams, the current amalgams, make sure there's no overhangs or suspicious density changes around that restoration. I'm going to look for composite restorations, and we know there's so many varies in radiopacity for our composite restorations based on the age of our patient and when they had that composite placed. So I'll also be looking for crowns and bridges and implants. Maybe I'm looking to see if there's any root canal teeth or bases or liners around some of these restorations to help me focus on denoting if something is a restoration or pathology, right? So sometimes when you focus on those restorations, it helps you with identification. And then I'm going to be looking at my bite wing radiographs to evaluate for caries. I'm going to be looking for those radiolucent notches in the enamel, maybe some triangulation, triangular radiolucencies that maybe have gone through the enamel into the dentin. I might be looking to rule out cervical burnout. I might be looking for recurrent decay underneath some of those restorations, any suspicious lesions. So sometimes there might be something that's an early, right? We know that early things are harder to detect. So I might have to cross-reference the bite wing radiograph with the periapical to see if something looks a little bit different when I see like a radiolucent notch or something in the enamel. And we know that's why it's so important that we don't have overlap on those bite wings. We need to have an open contact. So that's why I said it starts with those quality images so that you can properly look at all of the things and assess them correctly. For some reason, I always check for decay before I check for periodontal issues. I don't know why that is. I think it's just easier for me to look at those bite wings and look for any early signs of decay or recurrent decay around the restorations that are there. And then I move right on to looking at the supporting bone. So I'll look all across the dentition at the crustal bone height and the contour. I go right to the trouble spots too. I want to look between the maxillary first premolar and the canine, and I want to look between the mandibular second premolar and the first molar. Those tend to be dead giveaways for us to see if there's early signs of disease, if that patient has had a history of periodontal issues before, and if there's any change in that crustal bone height or contour. And then I will look and scan specifically for horizontal bone loss throughout the two arches. And then I'll tend to hone in on specifics of triangulation or vertical bone loss. And the last thing I check, I don't know why, is furcation involvement and calculus deposits. Although as a hygienist, we all know that the calculus is what gets us excited. So if there's calculus on a radiograph, that tends to be the first thing our eye goes to. I try to force myself to not get too excited about that and kind of hold off until after I've assessed the periodontal structures in order to do that. And then after I've looked at the caries and I've looked at the periodontal health of the bone supporting structures, I'm going to look for pathology. Maybe there's pulpal stones or calcification or a possible abscess or some kind of cyst or granuloma or something that's present. And I know our eyes tend to go there, but the reason why you have to have a system is because you don't want to miss something because something is like a beacon staring at you. You know, if you got like a big flashy green light saying, "Hi, I'm a cyst, I'm over here," you don't want to lose sight that you need to still check and assess for things like caries, and you still want to check for periodontal issues. So it's really important that you get a systematized approach so that you don't miss anything when you're taking a look at your patient. And when I mean by looking at everything, when you're in school, they kind of give you like a checklist, a cheat sheet of everything you should look at. That's why they do that. They want you to get a system down so that if in fact you do have a crazy thing show up on a radiograph, you haven't overlooked some of the important things that you need to. Like, for example, things to evaluate on a radiograph would be tooth development and abnormalities, right? Eruption patterns. Is the eruption pattern correct on your patient? And is there a malpositioned or missing tooth that should be in the dentition based on the age of the patient, but it's nowhere to be found? Um, Definitely identification of all the different dental materials. They show up differently on the radiograph, either radio opaque or radiolucent. So you want to make sure that you're not thinking something is a dental material when in fact it could be decay. So make sure you're always cross-referencing your findings on the radiographs with the clinical presence in the mouth and what your patient presents with. You want to look at all the areas on those radiographs to make sure and look for patterns so that you can see. And the other thing that's great, if available, you want to be able to review the previous radiograph if there's a comparison. So you should never look at the previous radiographs when you are evaluating the current radiographs. You want to review them after. So you don't want to have like a biased look at these radiographs. You want to have a fresh set of eyes. That's my own recommendation to you is look at this full mouth series or x-rays that you are evaluating with fresh eyes. And then after you've done a complete radiographic interpretation, then you can reference a previous set of x-rays to say, let's see if there's been any changes. Let's see if that's been progression, right? You want to check for progression. You want to check for change. You want to check for stability. Those are kind of things that help you when you're looking at like your patient's risk factors or symptoms, signs, and significance. If you think about, comparing the findings, if somebody shows up with a new area of decay, that could be a concern. But if you look at the previous radiographs and they're a couple of years old and it hasn't changed at all, it might not be as significant as maybe you first thought when you were doing your interpretation. So use the previous radiographs once you've completed your radiographic interpretation on your current x-rays. And you want to make sure that you document all of your findings. Document what you see, location, size, and appearance of any findings, and any limitations of the images, right? You might say that there were 3 retakes. That might be something. Or if the patient has mandibular tori, which may impede your ability to see certain things on the mandibular premolars, just as an example. I'm just throwing that out there because you want to make sure that you are documenting everything. This is such an important skill for you to develop, and I know that a lot of you have trouble with identifying all of the anatomy and all of the landmarks, and we do put you through the trenches to develop a system. And the reason why is because we're trusting you. We are trusted by our patients to interpret these radiographs. And yes, it's ultimately the dentist who has to make the final diagnosis, but the dentist relies heavily on you as a provider, as a clinician, to do an interpretation of those radiographs and work together as a team to come up with the findings. So we want to make sure that we have accurate periodontal and caries risk assessments completed, and those kind of go hand in hand with the interpretation of your radiographs, and those diagnostic radiographs actually support your findings when you come up with your risk assessment, both perio and caries risk. It also is such a great tool to communicate with your patient. I love the new AI tools that has like the red, yellow, and green, because our patients can understand when there's bone loss there and it's showing the red or the yellow. Patients understand what red, yellow, and green mean. It really helps us explain to them stuff that it took us a long time to learn about, helps us explain in very simple terms what we're looking at and what's a concern to us after we've done our interpretation. All right. And then the other thing I just want to share, okay, with you guys is when you're doing your radiographic interpretation, you want to make sure that you have a process that allows for a comprehensive evaluation of the entire dentition. You don't have to follow the same order that I shared that I do. As long as when you are completed with your radiographic interpretation, you have looked everything over and everything has been evaluated and documented by you. I hope in this episode that you gained some knowledge and some understanding of radiographic interpretation. If you want to streamline your learning and get more support for this, there's always stuff in my show notes that you can connect with. If you're having trouble with radiographic interpretation, I'm always here to help you and support your efforts to really nail this stuff down. All right. Other than that, I want you guys to have a great week and I will see you soon. Bye bye.